dignitaries and the members of AOIWB. First of all, I would like to thank everyone to be attend here in this clinical meeting. Just to elaborate a few points regarding what is this clinical meeting. This clinical meeting is being organized since years. Dr. Jain Gurtu sir is here. He is sponsoring this clinical meeting, and it is conducted throughout the year in different centers like medical college, like NRS, like KPC Medical College, and throughout the years amongst the participants, the first and second one are selected by the judges, and they are awarded in our state conference. So this is in a very nutshell regarding what the clinical meeting is. Now I would like to invite Professor and Head of the Department of the NRS Medical College, Department of ENT and Head and Neck Surgery, Professor Dr. Sumanto Datta sir. Sir, please come on the dais and address the dignitaries.
Good afternoon, everybody present in this August gathering. Heartiest welcome to you all. We, as the team members of Department of ENT and Head and Neck Surgery, NRS Medical College, feel humbled to host such an prestigious monthly clinical meeting in this institute. And for this academic session, this is the first monthly meeting. We are privileged in that sense. We are thankful to the Association of Otolaryngologists of India, West Bengal branch for this. In this gathering, we have our principal sir, Professor Dr. Pidboron Chakraborty. May I welcome him to the dais, and Dr. Sanchari Nandi is requested to felicitate him. Dr. Professor Pidboron Chakraborty sir. Dr. Sanchari Nandi, senior resident of this department, is garlanding him. May I now welcome Professor Dr. Indira De Pal, our MSVP madam, to come on the dais, and Dr. Nandi is again requested to felicitate her. Thank you, madam, for your valuable presence, even in your busy schedule. I now request Professor Dr. Soma Gupta, Dean of Student Affairs of NRS Medical College, to come on the dais, and Dr. Nandi again will felicitate her. Thank you, madam, for your valuable presence here. Now I request senior member of our association, Dr. Jain Gurtu sir, to come on the dais. Sir, please. Thank you, sir, for your valuable presence in this August gathering. Now I request Professor Dr. Haradhan Boda, President of AOIWB, immediate past President of AOIWB, please come on the dais. Thank you, sir. May I now request Professor Dr. Pitboron Chakraborty to garland Sister Nivedita and inaugurate this session. Madam Dr. Pal and Dr. Gupta are also requested to help Principal Sir. Please, Madam. Thank you, sir and madam. Now I request Professor Pitboron Chakraborty to say a few words in favor of these issues. Thank you, sir.
Very good afternoon to everybody, MSBP madam, Dean madam, and so many learned persons of our state of this ENT discipline. Actually, I am very happy that Dr. Datto, Professor Datto, could organize such a good clinical meeting. I have heard from him that I think this is the unique for ENT. This regular monthly clinical meeting, I don't know whether the other disciplines they organize it or not. I think not. Anyhow, it's definitely we are fortunate that you have selected NRS Medical College this month to organize this meeting, because NRS, you know, all of you know that it is actually celebrating the 150th year. So in that way, it will be definitely befitting of this organization to select this medical college. And just few things I can tell you, I like to share with you rather, because you are very learned persons. I cannot say anything of your subject. But as an administrator, I like to say something because you are very seniors. What I feel that I want to share, that there is some gap between the senior teachers and the junior teachers and the students. And this gap is gradually increasing day by day. So by that actually, we are not producing a very good group of future. It is definitely, it is true, like anything, that when we were junior doctor, we had a very beautiful relation with the seniors. The seniors used to rebuke us like anything, but we had a sweet relation. We could learn from them, and there was no actually, the seniors were not miser to share their knowledge with the juniors. All the times, they used to help us, they used to teach us, you do it, go, you do it. I am standing over here. I am taking rest in just the room beside. You call me if you cannot do. It is like that. They were actually used to force us to learn. This is not the case right now. What I feel, maybe that you may differ. But now the RMO or assistant professor level, they are not very close to the SRs. They are not very close to the house staffs. So by that, the house staffs, they are also not eager to learn. Definitely so many other causes are there. The house staffship in our time, who used to take the house staffship, they used to actually stay in the same subject. That was the thing. They were very keen to learn. But nowadays the house staffs, they do not know in what subject he will get the post graduation. That's why definitely some lack of seriousness is there. But it is also true that if we do the house staffship very sincerely, in any subject, there will be development of some skill, particularly the skill of communication. It is, I tell them, the junior doctors here, more or less every day when they meet us, that this communication of skill is develops actually in the house staffship. It is very, very important. May it be ENT, may it be eye, may it be general medicine, may it be general surgery, any discipline. Actually, this skill is very important. He may do post-graduation in any subject, but this skill is constant. So for this, you people, the senior persons, they are also responsible. We just doing the service period, just we are going to superannuate, so what's the interest? It is not like that. We will be responsible for their behavior, their maturity in every aspects. Not only in the knowledge of the discipline, but also the other things, how to tackle the patient party, how to actually face the very difficult situations, how to face the patient party to announce some bad news or like that, all these things. Actually, you are responsible. We, the senior persons, are responsible to teach them. So that point actually I like to share with you, that if all of us try to improve the standard of our future, we must take the responsibility. We cannot just fly away. So this is my request. I think all of you will actually share with me, and I pray to God that this clinical meeting, which is very unique one, this comes actually as a grand success, and all of you just learn from others. That is the actually importance of such clinical meeting. And I don't like to hesitate that very few junior faculties are here. Very few, I think. I don't know. I don't know. Definitely in every medical college there are so many faculties in ENT. So junior teachers are, yes, again, there is some gap. Anyhow, I hope for the best for the next clinical meeting, where the junior teachers will be much more. Thank you.
Thank you, Professor Dr. Pitboran Chakraborty, for your kind words. And now I hand over the mic to Dr. Debobroto Das for the clinical meeting itself.
So with the permission of the dignitaries on the dais and off the dais, I am starting today's clinical meeting. The first speaker of today's meeting is Dr. Rupsha Saha. Her topic is perichondritis in a case of Goldenhar syndrome with ER discharge, an unusual presentation. Dr. Rupsha Saha. Presentation is 8 minutes, and you will be asked questions on your topic for the next 2 minutes, and the questions will be only asked by the judges. So, and on the basis of which your presentation and answer, you will be graded. So that's it. Over to Dr. Rupsha Saha. And just 30 seconds prior your ending of the session, you will get an alarm from our side.
Very good afternoon to all the delegates present in the hall. I am Dr. Rupsha Saha, second year postgraduate trainee of Midnapur Medical College and Hospital, Department of Otorhinolaryngology. Today I would like to present something unusual that we received in our outpatient department, a case of perichondritis in the case of Goldenhar syndrome with ear discharge. Now, what is this Goldenhar syndrome? It is a rare developmental disorder affecting the first and the second branchial arches. It is also known as oculo-auriculovertebral syndrome, characterized by malformations classically involving face, eyes and ears. In the year 1952, Dr. Maurice Goldenhar described this syndrome with a triad of accessory triggers, mandibular hyperplasia and ocular dermoid. The signs and symptoms usually vary in severity from case to case. However, external ear anomalies and ipsilateral fascia underdevelopment may be stated as the main clinical features. One of the most common signs of golden heart syndrome is, however, hemifacial microsomia. Other signs and symptoms may include congenital heart defects, mental retardation, scoliosis, strabismus, coloboma, obstructive sleep apnea, and so on. Now, the case which I would like to present is that of a 10-year-old female child who came to our outpatient department with right ear pain and discharge for a duration of 1 week. The patient was apparently well 2 weeks back, following which she developed pain and swelling over her right ear following an alleged history of trauma. 1 week later, she suffered from a small episode of upper respiratory tract infection, due to which she developed right ear discharge. The whole episode was associated with high grade fever. However, there was no history of nausea, vomiting, vertigo or tinnitus. The child presented with maldevelopment of external auditory canal, left side since birth, along with curved spine and underdevelopment of left half of face with malocclusion of teeth. On physical examination, she had right-sided preauricular tag, left limbal dermoid, left-sided facial asymmetry along with scoliosis. Her facial nerve function was apparently intact. The patient was born to non-sanguineous parents with unknown family history. These are the pictures which show right-sided preauricular tag, left-sided microtia, scoliosis and left limbal dermoid. The patient was examined. The findings are stated. Right on her right pinna, there was perichondritis with tenderness and inflammation, and microtia on the left. He had preauricular tags, as already mentioned earlier, over her right ear, and the postauricular region apparently showed no abnormality. Her left external auditory canal was atrophied, while the right was filled with thick purulent greenish discharge. The mastoid tenderness was bilaterally present, and tympanic membrane could not be examined bilaterally. The discharge, initially though scanty and serosanguinous, gradually became progressive and greenish, foul smelling and purulent in nature. Rini's test was conducted and it was negative bilaterally. The patient could not appreciate Weber test, absolute bone conduction test, vestibular function test, test for facial nerve function and fistula test were apparently within normal limit. Her systemic examination was also done, as multiple systems are involved in golden heart syndrome usually, like her cardiac system, respiratory system, GI system, genitourinary system, including her ocular visibility. And no such significant finding was found, apart from the fact that she had a recurrent history of upper and lower respiratory tract infection since childhood, and she was even admitted in the hospital for these recurrent infections. Her routine blood investigation was carried out. All came within normal limit, except that the total leukocyte count amounted to around 26,500, which may be attributed to the fact that the patient had active inflammation. Swab was sent for culture and sensitivity from her ear discharge. This is the report. The culture came to be highly positive, with heavy growth of Pseudomonas aeruginosa, and the patient was unfortunately resistant to all the empirical antibiotics apart from amikacin and gentamicin. These are a few radiological findings. Her CT scan of a temporal bone showed bony atresia of left EAC, hypoplastic middle ear cavity, mild deformed ossicles. Her lumbar spine X-ray showed multiple lumbar vertebral defects. In the next slide, we can see two skiagrams which show fused vertebra and left mandibular and maxillary hypoplasia and hypoplastic left upper premolar and molar tooth. The patient was 20 kilograms in weight, and accordingly she was treated with amikacin and dexamethasone. Topical antibiotic ear drop was used, regular dressing was done, and suction clearance of the discharging ear and followed by oral toileting with topical antibiotic was also done. After suction clearance, a perforation with irregular margin, likely traumatic, was noted in the tympanic membrane of the injured ear. The patient was discharged in a stable condition with reduction of the symptoms like pain, fever, ear discharge. She was eating well since 2 days before discharge. She was asked to come for a follow-up every week initially for 4 weeks and then every 2 weeks. She was also sent for orthopedic, pediatric, cardiological, ophthalmological and dental opinion. The patient attends our outpatient department at regular intervals and no recurrence has been noted till date. Now, to summarize the treatment approach, the fact that the spectrum of phenotypic features is variable, the treatment of Goldenhar syndrome necessitates an individual, multi-stage and multidisciplinary approach. The treatment is usually begins early in life and continues for a long period of time. The already diagnosed signs and symptoms may exaggerate and the newly diagnosed signs and symptoms may come up over time. Treatment of the patient with Goldenhar syndrome is a rare congenital defect. The spectrum of observed symptoms and the severity differ among affected patients. It is usually considered to be a culmination of environmental and chromosomal factors. Mostly, these are found to be sporadic in nature. Thus, to conclude, we believe that to achieve the satisfactory and treatment results, involvement of a team of different specialists is crucial. It is also essential to understand patients and his family needs, meet their expectations, and establish viable and individual treatment plan. Proper interdisciplinary, well thought out treatment can lead to acceptable quality of life of patients with Goldenhar syndrome. This presentation was to emphasize and to create awareness regarding this rare disease called Goldenhar syndrome. I hope the presentation was informative. Thank you for your patience listening. Thank you.
Thank you. Am I audible? Hello.
Yes, yes.
This is essentially a first and second touch, you told me, defect. Can you name some other syndromes of first touch, defect like that? One or two?
So,
usually we come across in ENT OPD.
Yes, sir. All the preauricular sinus defects we have, preauricular sinus, then branchial fistula, these are usually the first and second branchial arch defects which we face.
Have you heard the name of Treacher-Collins Spear-Robinson?
Treacher-Collins syndrome, yes, sir.
Now, one thing, how can you say, by sure that this is the case of GS? Did you do any chromosome study or some genetic study?
No, sir. It was a clinical diagnosis only.
And the last question is, did you find any extra problem in treating this patient with other patients having pericarditis and COM? Any other findings?
So actually, after we we studied the Goldenhar syndrome. We don't receive much cases of Goldenhar usually. So there's a chance of immunocompromised status in case of such patients. So considering the age of the child, she should have responded. Initially, we started her treatment with the empirical antibiotics only till her swab culture came. So, but she wasn't responding very well. So at the tender age of 10 years, usually such resistance pattern is not seen. But as I already mentioned, she had suffered from a number of upper respiratory and lower respiratory tract infections in her early life. She was even admitted in SNCU post her birth. So due to that, she and she was treated again and again with IV antibiotics of various kind. She already, maybe for that reason, she already developed resistance to all the empirical treatment that could have been given. So we had to go for amikacin. It is already we know that it is cochleotoxic, vestibulotoxic. So, but still we had to go for amikacin or gentamicin treatment because he was resistant to all the other drugs. So her immunocompromised status was a hurdle for the treatment.
Listen, you are presenting the case
Yes, sir.
as because it has been presented as a case of perichondritis,
Yes, sir.
and according to you, it is an unusual presentation. Are you sure about that? What are the diagnostic triad of golden heart syndrome?
So the diagnostic, as it is called the
Minimum diagnostic criteria or diagnostic triad of golden heart syndrome.
there should be ocular finding.
Ocular finding is there.
Yes, there was. sir.
Then
She had limbal dermoid
auricular appendages are there.
Auricular
And the
appendages
third
are-
one?
and vertebral findings were also there.
No.
Mandibular hypoplasia was there.
Third one is?
Man
No. What you have presented in your slide. Go to that slide. Triad.
yes, sir.
Then introduction. Second or third slide.
So these were the main findings we have found. As I have mentioned it to be the ocular auricular vertebral syndrome. So she had tried of all the three things. That's
No.
why we made a clinical diagnosis.
Actually, in ocular syndrome, auricular appendages and oral fistula is the other third criteria. That's why perichondritis is not that common. Okay, maybe in your case it is uncommon, but if we talk about golden heart syndrome, there is a three primary symptoms: epibulbar dermoid,
Yes.
auricular appendages, and oral fistula. Because of oral fistula, or better to say colo-oral fistula, patient may develop recurrent perichondritis.
Perichondritis.
That's why she presented with perichondritis. This is not that unusual. Anyhow, a good case. Thank you. Thank you.
Okay. Thank you.
Sorry, another just one. This won't carry any, I mean, negative marks, just for interest.
Yes.
Can you name the nationality of, I mean, golden,
Yes, sir.
the nationality of the, I mean,
No, sir.
he was from Switzerland actually.
Switzerland.
Yeah.
Okay.
Was there an ENT or an orthopedician?
Ophthalmologist. He was
Huh?
an ophthalmologist.
Yeah, thank you.
Thank you.
The next one.
Thank you very much. Thank you very much, Rupsha. The next presenter is Dr. Aisha Shreen. Her topic is delayed health-seeking behavior in COM patients, an observational study.
Good afternoon, everyone. I'm Dr. Aisha Sharan. I'm a second year PGT from IPGMER at SSKM Hospital. My today's topic is delayed health-seeking behavior in chronic otitis media patients. It was an observational study. Chronic otitis media is actually a neglected disease, and why I am saying it is because ear discharge is considered as a normal part of childhood by many of the parents in developing countries, including India. India is having a prevalence of 5.2%, which is actually very high. As you can see in this picture, India is considered to be a high prevalence state according to the WHO bulletin. This figure was from a WHO bulletin, and you can also see that the COM prevalence is more in the tropical areas. So recently the COM was actually added to the expanded list of neglected tropical diseases by WHO. And the hearing impairment due to COM in India is more than 40 per 10,000. That is the highest in the world. And it is also the commonest cause of hearing loss in children according to the recent NRHM statistics. Now what is important regarding the hearing loss is that this hearing loss is actually a very avoidable cause of hearing loss, which is leading to the poor scholastic performance, delayed speech development, and poor cognition in children. And it is constituting to a DALY of 4.68 million years million due to according to the global burden of disease study in 2010. So basically the timely and adequate management, whether it be of acute otitis media, whether it be of otitis media with effusion or an early stage of chronic otitis media, that should be done timely and in an adequate manner so that we can prevent the complications and also the hearing impairment. My objectives during this study was to evaluate the prevalence of delayed health-seeking behavior among the COM patients. Here the delayed health-seeking behavior was taken as more than 6 months from the onset of symptoms, and to identify the various factors which which is leading to this delayed kind of behavior, and also to analyze the prevalence of hearing impairment in these kind of patients. It was a cross-sectional study done between January 2023 and March 2023, and the sample size was taken as 103. The recommended sample size was 95, and we took it as 103. And the question, it was a questionnaire-based study. This was the questionnaire that was given. And the participants were the patients with COM who attended the ENT OPD of our hospital. The statistic analysis was done with SPSS 16. And the results in a demographic manner, it was basically the gender preponderance was more or less similar, but most of the patients were coming from a poor socioeconomic strata and also from rural areas. You can see that most of the patients belong to either second class or a third class of modified BG Prasad scale, and more than half of them came from rural areas. They were mostly unskilled laborers, and formal education was present in almost 70% of the individuals. And one thing regarding the symptoms was that most of the patients, 93% of the patients had a delayed health seeking, that is more than 6 months of onset. And also 63% of the patients out of this had hearing loss, and of the total people who are having hearing loss, 77% had a delayed health seeking behavior. So that itself shows that delayed health seeking can have an impact on hearing. And the lack of awareness regarding why the patient is having a discharge, what are the causative factors and the possible complications. This lack of awareness was very clear during the entire course of the study, and only 34% of the patients at least knew something about the disease they were having. The first contact healthcare system was mostly private rather than a government setup, and the first contact healthcare professional was either a specialist or a general practitioner. Now comes the important part. The treatment received at the first contact was mainly modern medicine rather than a referral. That is, most of the patients who attended the periphery, they were even though they were having a case of chronic otitis media, they were still getting continuously treated with oral antibiotics and these kind of medications. Once the symptoms are improving, patients go back and patients again go to the same doctor when they get the symptoms back. And it was seen that most of the patients went to the primary contact for more than 5 times before a proper referral to higher center was done, and this led to a delay in their visit to tertiary care for a definitive management. And some minor factors were that at the tertiary care center also they had to face some delay due to the heavy rush in OPDs and also due to the long waiting list for investigations. And coming to the financial barrier, they were many of them had an average of 5,000 rupees expenditure for this disease, and considering their socioeconomic status, it was a little bit high for them. And coming to the discussion, so major factors leading to the delayed presentation, but we have understood from our study is that the lack of knowledge regarding the disease process and the probable complication is very less. You can see that most of them were not aware, and most of them told us that if we knew that this much complications or hearing impairment might happen, then we would have went for treatment earlier. And the one side by side is the diagnostic delay. Diagnostic delay at a peripheral level is basically because of the lack of training and lack of understanding regarding the management, how to diagnose the case of AOM OME or COM, how to differentiate between them using an otoscope. So these all things are lacking at a peripheral level, and the infrastructure like otoscope may not be available at all peripheral centers. And also, we all know that IMNCI and also NPPCD has clinical algorithms to be followed for each and every ear disorder based on the symptoms. But a pure non-compliance to this algorithm was seen during my study. And other factors were accessibility issues and financial barriers, and also due to the poor effect of quality of life, they were having delayed presentation. This is the these two are the algorithms, and basically there is no safe COM concept. So basically we should be ideally referring each and every patient to the secondary center. So my conclusion and suggestions would be to make more health awareness programs, training of health professionals, introduction of video otoscopes as we have telemedicine, and root level workers should be more trained for knowing the danger signs, adherence to clinical algorithms and revision of the same if needed, and infrastructure should be properly utilized, and also screening programs for early detection and also vaccination programs must be done to reduce the incidence. Thank you.
Thank you very much. You have just covered all the things, but what is the bottom line of just your advice? I mean,
Sir?
bottom line of the thing, Pura.
So basically,
Just 1 or 2 words only.
the most common factors which are affecting the delayed health seeking behavior is the lack of knowledge and also the diagnostic delay that is happening at the periphery. So these two problems should be properly addressed by either by health education programs and also by adequate training at a peripheral level, how to identify all these disorders, how to use otoscopes for the for diagnosis, and also we should introduce more infrastructure facilities so that these all are possible.
Also to educate about the hygiene also,
Yes,
to educate about this.
Sir, that will come in health education part.
Okay.
Sirin, it's a very good paper, but
Thank you,
I
sir.
want to know that why this 6 months cut up between
Sir,
the delayed and non-delayed presentation.
Sir.
How you have fixed this? Do you have any literature review or
Yes,
something
sir.
like that? Just tell me some of the references where you get this 6 months cut up.
Sir, in my references, I have kept the studies. There was one, this was, sir, causes of delayed healthcare seeking in this chronic otitis, suppurative otitis media, Rwandan tertiary,
Okay.
knowledge, attitude, practice. Sir, basically what happens is that chronic otitis media is whenever a discharge is persisting for more than 3 months, and we are giving a time of 3 months more for the patient to
So this
seek
is your
help.
own institutional protocol actually, huh?
Yes, sir.
There is no such
Sir,
fix it in
based
literature.
on
Anyhow,
sir, based on previous studies also, this was
Okay.
taken as
and this is a period prevalence between the month of January 23 to
sir.
March.
Actually, the sample size was
Is too small actually, huh? 103.
yes,
huh?
sir.
What your data said, that 40 per 1000 population. And if you take a period of 2 months, what could be the number of patients in your OPD? It is not 103 COSM cases.
No, sir. Basically,
It
what?
should be more than 2000 or something like that. Huh?
Yes, sir.
Huh? Then how you have selected this 103 cases
Sir,
out of those
who-
2000?
So those who came, this study, data collection mostly was done by me, and it was basically a random kind. It was kind of a
This
randomization
sample
also.
collection was randomized as and when you were in the OPD actually.
Yes, sir.
This sample selection was randomized actually,
Yes, sir.
from the OPD patients.
Yes, sir.
Okay, but sample size is, remember, it's very good paper.
Yes,
But
sir.
with very low sample volume actually.
Okay, sir.
Very low.
I
You
will-
have to increase this.
Yes,
And
sir.
this could be a very good paper in future presentation or somewhere else actually.
Okay, sir. Thank you so much.
Increase your sample size.
Okay, sir.
Okay.
Thank you so much.
What is your message?
Sir, as I told you, in this clinical, we actually are making, actually by NPPCD program or IMNCI program, we are actually trying to understand and diagnose these kind of problems. But the problem is that, sir, when most of them are getting treated with antibiotics, and once this is the symptoms are getting reduced, the patients themselves are not giving an effort. One thing is that the patient is not going to the surgeon once more, and also the doctor who is treating is also not aware of the situation that it is actually a chronic otitis media. And
Thank you, Aisha, for throwing light on the ground reality of the otology once again. Our next speaker is Dr. Shouvik Mondol. His topic is islanded nasolabial flap for tongue reconstruction.
As students of ENT or as ENT surgeons, we very often encounter such humongous defects when we are operating on head and neck patients like tongue cancer patients following an ablative surgery. And we are constantly bothered about what should be the right choice for reconstruction of these defects. And there is a constant discussion and debate about the ideal way forward. Hence, ladies and gentlemen, my topic for today is the islanded nasolabial flap for tongue reconstruction. I am Dr. Shouvik Mondol, a first-year junior resident of Institute of Otorhinolaryngology and Head and Neck Surgery, IPGMER and SSKM Hospital. As we know, most commonly used flap for tongue reconstruction these days is microvascular free flaps. A good alternative to this is various kind of locoregional flaps, PMMC being our workhorse. And we can also use nasolabial random flaps for smaller defects. However, through the course of this presentation, I'll share with you the experience in our institute. What we felt was why the islanded nasolabial flap could be a much better alternative and could even be the choice of locoregional flap for tongue reconstructive surgeries. This was a retrospective analytical study set in the timeline of January through June of 2022 in our Institute of Otorhinolaryngology and Head and Neck Surgery. In this time frame, the islanded nasolabial flaps were applied for 11 patients, and we assessed them on the parameters as follows: age, sex, their clinical T-stage, their pre-operative speech intelligibility score, and 3-month post-operative speech intelligibility score, along with the complications that they encountered. So when we go to the surgical technique, the decision for going for a nasolabial islanded flap should be taken in advance while keeping a few things in consideration, as in these cases, the facial artery and vein must be preserved, which might otherwise be sacrificed in some other cases. And also, assessing the skin laxity is very important, otherwise we might encounter difficulty while closing the donor site. Moving forward, the flap is usually fusiform in shape and of the dimension that should usually mimic the tongue defect. It shouldn't be more than 3 centimeter in width, as that will give us problems while closing it up. The superior limit is 1 to 2 centimeter below the medial canthus so as to prevent ectropion, and the inferior limit is at or just below the anterior commissure. The medial level should be 2 to 4 millimeters lateral to the nasolabial fold in order to get better cosmetic outcomes. Now, coming to harvesting of the flap site is first locally infiltrated, then the harvesting is commenced in a superior to inferior direction. The skin and subcutaneous fat is incised and we identify the buccinator muscle. After that, the facial vein is identified and clipped at the superior aspect of the flap. The dissection plane that we try to achieve is facial vein above and the buccinator muscle below. In some cases, some part of buccinator muscle is also taken along in a superior to inferior direction. The medial incision is completed so as to identify the facial arteries and all its branches directed medially from the artery is clipped. The dissection is continued further and the vessel is clipped high up in the flap and the lateral incision is committed at this point. Finally, the flap is completely islanded on the facial vessels and is delivered into the oral cavity either through the defect of the floor of mouth already or by splitting the mylohyoid muscles. And finally, the flap is positioned such that the superior aspect of the flap is placed anteriorly, as that has maximal chance of necrosis being distal to the facial artery, in order that in case any defect occurs, we can go for a primary closure or we can easily reassess about that. So this is a picture of our patient after the primary closure was done, and this is how the final outcome looks. Coming to the results, most of the patients among the samples we took were of male, 9 were male, 2 were female, 7 of them had a T stage of T2 and 4 had a T staging of T3. When we compared their pre-operative speech intelligibility score and post-operative SIS scores, we found that there was a statistical significant difference, and that is quite accepted in an ablative tongue surgery. But what was more interesting was when we compared through an independent T-score with the patients undergoing primary closure of tongue, there was no statistical difference. So it is very safe to say that even the patients undergoing islanded nasolabial flap had equally good SIS outcome as compared to patients undergoing primary closure of the tongue. Coming to complications, 4 patients experienced the complication of marginal mandibular nerve palsy, 2 experienced flap loss, 1 had orocutaneous fistula, and the rest 6 had an uneventful postoperative period. So, coming to the discussion, there are a few challenges in tongue reconstruction. As I mentioned in my introduction as well, that microvascular flap is the way to go, but that requires an extensive surgical and anesthetic time, requires microvascular surgery setup, better skills from the surgeon, and in this manner we find that locoregional flaps are a good alternative. But PMMC, free forearm radial flap, all these flaps are really bulky, and that can be quite an issue, especially in female patients and also in post-operative rehabilitations of the patients, as they can experience stiffness, the mobility is restricted, and the quality of life that we are offering them is quite not expected. So there the NLF, that is nasolabial flap, comes into play, but it also has some restrictions because it cannot be suitable for patients with intact dentition and mandible. The specific advantages of the islanded nasolabial flap is it has a very long pedicle length, so it can reach anywhere in the mouth and it can seal the defect of the tongue and quite large defects as well. It can be applicable for dentulous patients as we are delivering it through the floor of the mouth, so it is quite similar to microvascular free flaps. It has less surgery duration and minimal hair growth as well. So I can very safely conclude that islanded nasolabial flap should be considered a locoregional flap of choice and an alternative to free flap for tongue reconstruction. This presentation would be really incomplete without thanking my mentors, Dr. Professor Arunabha Sengupta sir, Dr. Professor Debashish Burman sir, and Dr. Shubhadeep Karanjoy sir, without whose guidance this wouldn't be possible. Thank you one and all for a patient hearing.
Thank you, Dr. Shobhik. It was a nice presentation.
Thank you, sir.
Did you go for any neck dissection prior to this thing? I mean, what is your tumor classification? T1, T2, T3, like that?
Yes, sir. In most of these patients, the neck dissections were done prior to the primary tumor excision.
Okay. And you have told everything, but I just want to know that this has a tremendous functional and aesthetic component also post-operatively. There is a score actually going through a name of a US city. Can you name that score? Something score you have to just, through which you can just tell the patient is having better, I mean, score like
if
that.
I'm Frankfurt.
It is a Washington. It is Washington questionnaire 4. Okay.
Okay.
Thank you.
Shovik.
Yes, sir.
Your one is islanded nasolabial flap. And you presented mostly the flaps are superior based.
Pardon, sir?
Your flap was superiorly based.
Yes, sir.
No note about inferiorly based flaps in your study.
No, in our study, we islanded it in
Superiorly.
superiorly, yeah.
Number one. Then you are claiming that it's a very good flap.
Yes,
No?
sir.
What are the criteria of a good flap?
So, the criteria for a good flap would be, first of all, less chances of necrosis, that is good acceptance rate.
Yeah.
Another factor which we should consider is that donor site, how is the donor site functioning? Like in PMMC or other locoregional flaps, we see that the donor site is really in a poor state and there is less mobility in those patients. Moreover, the surgical time and anesthetic time is less in this kind of flaps. There is no microvascular surgical setup needed, and in tongue reconstruction surgeries, in locoregional flaps, patients very often experience hair growth, which is a big problem to them. Maybe
haven't you omitted the one major part, that is the function of the organ? You have mentioned nothing about function of the organ.
Yes, sir.
Actually, a good flap should have primarily 3 criteria. Forms, I mean good formation, function, good function, and aesthetics.
Yes, sir.
You said nothing about the function of the tongue. Then how did you measure the outcome of this flap? When the patient can speak intelligible words, when the patient can take food orally, at what day? These are the more important parameters to measure the outcome of a flap.
Sir,
you haven't mentioned anything.
Sir, I did mention about the SIS scores, speech intelligibility scores. However, during saying I agree, I missed out on mentioning that it provides good mobility to the tongue and good bulk.
All they had tracheostomy. All of them.
No, no, sir. Not
No.
all of them had tracheostomy.
Okay.
Thank you.
No.
Thank you, Shobik. In spite of all the hard questions and answers, you showed us that we ourselves can do the tongue reconstruction with nasolabial. One thing I like to mention here that all of you are postgraduates, and without the help of your teachers you cannot present. But as it is a competition, you cannot mention the name of the institute and your teachers because it can create a bias. So my request is to please do not mention it. The next topic is bit interesting, new to me as well. The name of the presenter is Dr. Vyush Nag Mukherjee. The topic is significance of platelet-rich plasma therapy on short-term post-operative outcomes of pediatric tonsillectomy patients.
Good afternoon, my respected teachers, judges, seniors and colleagues. Today I present my case, significance of platelet-rich plasma therapy on short-term postoperative outcomes of pediatric tonsillectomy patient, which is a prospective observational study. So, what is PRP? PRP is an autologous substance that has found in different aspects of surgery, and its healing power is attributed to abundance of its growth factor. Not only it used in traditional hemostasis, it also used in different stages of wound healing in different various mechanisms. It constituents are different types of growth factors, and those growth factors helps to form myofibroblast cell and ultimately enhances the wound healing by collagen aggregations. PRP has been traditionally used in different non-healing ulcer, alopecia, musculoskeletal injuries, in different dermatological signs, and its biostimulation and healing acceleration also used in bone and wound healing process. PRP also used in atrophic rhinitis in ENT, head and neck ulcers along with tympanoplasty and hearing loss. So, we endeavored to apply PRP over the tonsillar bed after tonsillectomy in pediatric individuals. My aims and objective of the study to compare the short-term outcomes of pediatric patients in PRP and non-PRP group in terms of postoperative pain, analgesia requirement, bleeding complication and duration of hospital stay. My study period is 6 months from 15 November 22 to 15 May 23. It's a purely hospital-based prospective observational study. Every alternate patient admitted for tonsillectomy surgery has considered to apply post-op PRP with proper consent. 40 subjects divided into two groups, pediatric tonsillectomy age group 4 to 12 years I taken, and 20 patients in the PRP group and rest of the 20 in the non-PRP group. Male and female pediatric individuals in between 4 to 12 years included in inclusion criteria. Along with parents and legal guardians give proper consent for the tonsillectomy along with PRP application, and patients suffering from chronic and recurrent tonsillitis, sleep disordered breathing and obstructive sleep apnea. And my exclusion criteria includes age less than 4 years and more than 12 years, and those parents did not give proper consent for the autologous PRP application, and patient had bleeding complication, other comorbid condition like diabetes, epilepsy, and the non-vaccinated individuals. So how the PRP is made? PRP is made before the OT procedure 1 hour back. Venous blood is drawn from the antecubital vein 10 ml. After that, the blood is put in the acid citrate dextrose tube. Then the tube is subjected to soft spin for 11 minutes in 1500 RPM. Followed by the supernatant which stands out is extracted and transferred to another tube with any anticoagulant. And this tube is now subjected to heart spin in 12 minutes in 3000 RPM. After that, the upper 2/3 of the resultant is platelet poor plasma and the lower 1/3 is platelet rich plasma. The platelet pellet is settled down at the bottom and it's shaken with 2.5 ml plasma and then extracted. I analyze the PRP in smear after centrifugation. It's more concentration of platelet than before centrifugation, and in PRP in platelet count is much more than the baseline platelet count, and also I put it in a graphical representation. In PRP platelet count is more than the baseline platelet level. So after tonsillectomy with securing the hemostasis, PRP was applied on the tonsillar bed, and showing in this video, PRP is applied in the tonsillar bed after tonsillectomy, 1.25 ml to 1.5 ml for each tonsillar fossa, duration 5 minutes, and confirmed to anesthetist, asked to anesthetist not to suck after the procedure, not to suck after post-tonsillectomy in the tonsillar fossa. So, my post-operative assessment includes post-operative pain score, which includes facial pain scale and visual analog scale, post-operative analgesia requirement, post-operative bleeding complication and duration of hospital stay. I taken 2 scale, visual analog scale and facial pain scale for post-operative pain assessment, facial scale for less than 7 years and visual analog scale for 7 to 12 years. The Wilcoxon sign rank test and Mann-Whitney U test applied for statistical analysis purpose, and Bonferroni correction for making the p-value. My results analysis: as the day progresses, the total mean pain value in the TPRP group gradually decreased than the non-PRP individuals, and p-value becomes more significant. TPRP stands for tonsillectomy along with PRP application, and TS stands for tonsillectomy alone. In my graphical representation, the post-operative pain score in the TPRP group much lesser than the tonsillectomy alone group, and number of additional analgesic requirement is less in TPRP group. I have given analgesic for the day 1 for 2 groups, PRP and non-PRP group. After day 1, it is given as SOS basis. It is shown that in TPRP group, number of additional analgesic requirement is less than the tonsillectomy alone group. And post-operative bleeding complication, I measured in qualitative scale. No bleeding occurred in the TPRP group in the early and late term, but in 2 patients in the non-PRP group, bleeding has occurred in 7th and 9th day as a secondary hemorrhage. I have given IV antibiotics followed by observation, and duration of hospital stay much lesser in TPRP group than the tonsillectomy alone group. So comes to the discussion part. Managing post-tonsillectomy pain is one of the important post-operative care. Various modalities are used, like pharmacological modalities and non-pharmacological. In this study, we use topical application of autologous PRP in post-tonsillectomy patient. Since it's a autologous platelet-rich plasma, it does not cause any hypersensitivity reaction, do not need any screening or cross-matching test, spread of HIV, HBsAg or any other blood-borne disease prevented. PRP is a safe, easily available autologous material that can be used extensively in tissue repair. The preparation is easy and application being simple too. I have taken 2 studies in 2019 and 23 in which they applied PRP in the post-tonsillectomy patients and reduced the complications. PRP is involved to decrease the expression of interleukin 17A and interleukin 1 beta to regulate the wound inflammatory response, and it promotes the reepithelialization by regulating the biological function of the epidermal stem cell and angiogenesis of the wound tissue. So PRP is used in a variety of therapeutic settings for the treatment of burns, heart bypass surgery, soft tissue ulceration and orthopedic surgery also. So my suggestion from our study, we found that PRP can be used as a safe autologous material for reduction of post-tonsillectomy complication. It thus holds immense prospect in future endeavors as far as ENT and head and neck surgery is concerned. In my conclusion part, so pediatric tonsillectomy patients along with PRP group is much superior than the non-PRP individual in terms of postoperative pain, complications and other bleeding and hospital stay. So this is my reference, and thank you so much to all of you. Thanks.
Okay, Dr. Mukherjee, thank you very much for this topic. What is the normal range of platelet in a given individual?
Sir, 1.5
normal
to 4.
count.
Normal count, sir, 1.5 to 4 lakhs.
Sorry?
1.5 to 4 lakhs.
Sorry?
Normal platelet value 1.5 to 4 lakhs ideally.
And what do you mean by platelet-rich plasma? There is a quantitative analysis.
Yes, sir.
How? What is that?
Sir, actually, I have taken 10 ml of normal blood, and after the centrifugation, there are 3.
I'm not talking. You have said that it is 1.5 to 2.5 like that. And when do you call it as a platelet-rich plasma? There is some quantitative analysis. I mean, that value has to be.
Means, sir, this
I
means
want that value only. When you will say it is a platelet-rich plasma, I am emphasizing the rich word, R-I-C-H. Okay. Just tell me the number.
Sir, 6 to 8 into 10 to the minus 5.
It is twice or slightly more than twice, okay?
Slightly more than twice, sir.
Yeah. And another thing, you have just done tonsillectomy in a control study and given PRP in some other patient. Wouldn't have been better if one tonsil has to be done, taken out, and another one in the fossa you can just give some PRP so that you can just assess the same patient's formation of bleeding like that. Because patient's pain or hemorrhage varies from person to person, the patient. Okay? This is the only observation.
You have scientific committee clearance before going for this study?
Sorry, sir?
Scientific committee clearance, your institutional scientific committee clearance. Yes. Did you get that? And why you are telling that it is an prospective analytical studies? Yeah, observational study. It is not observational. It is a purely analytical study. You should correct your heading actually. So it is purely analytical studies. So, but actually, what is the? But just I want to know actually why we feel pain after tonsillectomy.
Sir, due to non-healing.
Why we feel pain after tonsillectomy?
Sir, pain due to after tonsillectomy surgery there is bleeding and the area is
more
non-healed.
Severe than any other common surgeries. It is due to injury to the superior constrictor muscle. And you are just installing the PRP on the surface. How it could reach the inside of the muscle and reduce the pain actually?
Sir, due to growth factor presence in PRP, it helps
all
in
other applications of PRP
Hmm.
in joint injuries, tendon injuries, in baldness, in the dermatology, all are installation, injections. This is the first time I am seeing that PRP is being applied as drop and drop on the desired surface. I don't know whether how much it is effective actually. Have you any literature, the literature you are showing about those South Indian doctors, what did they do actually? They install it on the surface or they injected it within the muscle?
Saying still in the surface.
Have you gone through it?
Yes, sir.
Okay.
Thank you, sir.
Thank you, Vyush. We really had to work on the procedure to really know how really it helps or not. The next speaker is Dr. Mohammad Nadeem Hassan. Is he present? His topic is assessment of hearing loss in pediatric patients attending ENT OPD in a tertiary care hospital of West Bengal and observational study.
Good afternoon to my respected teachers and my colleagues. Today I am going to present a study on the assessment of hearing loss in pediatric patients attending ENT OPD in a tertiary care hospital of West Bengal. Coming to introduction, the hearing loss is the most common sensory deficit in the humans globally. Among 6.3% of the Indians with hearing loss are present, among which the large population is of children aged 0 to 14 years of age. Children who are not screened at birth, they go unidentified until 3 to 4 years of age because of the lack of visual indicators. Early and prompt hearing screening with timely rehabilitation can prevent debilitating hearing loss in adult life. The aims and objectives of the study are as follows. Aim is the assessment of hearing loss in pediatric patients between 6 months to 12 years of age attending our OPD. The objectives were as follows: to find out the proportion of pediatric patients with hearing loss, to find out the risk factors, and proper follow-up and rehabilitation of the children. The materials and methods are as follows. The sample size was 200. The study period was 6 months from 1st November 2022 to 1st May 2023. Type of the study was observational cross-sectional study. The study population was 200 children from the age group of 6 months to 12 years. The inclusion and exclusion criteria are as follows. We included children between 6 months to 12 years of either gender attending our OPD, and the exclusion criteria were severely sick baby who required admission, presence of craniofacial abnormalities like microtia and anotia, untreated otitis externa, acute otitis media with ear discharge, acute mastoiditis, and refusal by parents to consent for the study. The methodology is as follows. First, proper consent was taken from the parents and the attendants of the children. Detailed history taking was then taken regarding the child's hearing, speech, and the scholastic performance. Clinical examination was then done with headlight and otoscope. Impacted wax, if found, was cleaned. We followed the following hearing assessment protocol. 100 children from 6 months to 5 years of age underwent OEE, that is otoacoustic emission testing. If OEE came as refer, a repeat OEE test was done after 2 weeks of interval, and then the repeat OEE came as refer, the BERA test was performed. In the next 100 children, 6 years to 12 years of age, they underwent PTA and tympanometry. The data was tabulated in using Microsoft Excel, and calculation of hearing loss was done. The results of OE test are as follows. Among the 100 children, 78 passed bilaterally, 7 were shown to have bilateral refer, and 15 were shown to have unilateral refer. Repeat OE test was performed, and in the repeat OE of the 22 children, 10 children passed bilaterally, 5 were seen to have bilateral refer, and 7 were seen to have unilateral refer. BERA was done on the 12 children who were found to have refer on the repeat OE. Among those 12 children, 2 were seen to have moderate sensorineural hearing loss, 6 were seen to have severe sensorineural hearing loss, and 4 were seen to have normal hearing. Among the 100 children who were done PTA, the results of the PTA test are as follows. 11 children were found to have mild conductive hearing loss. 4 were seen to have moderate. 1 was shown moderately severe conductive hearing loss. 2 were seen to have sensorineural hearing loss, and 82 children were found to have normal hearing. The results of tympanometry curve are as follows. Type A curve was seen in 168, type B in 20, and type C in 12 out of the 200 years. 100 children, 200 years examined. Now, presenting with the clinical and the audiological parameters of all the children in our study, the diagnosis of various diseases are as follows. Acute otitis media was seen in 5 children, chronic otitis media in 11 children, otitis media with effusion was seen in 3 children, and eustachian tube dysfunction was seen in 6 children. 10 children found to have sensorineural hearing loss, bringing the total to 35 children. This is a pie chart which is showing the percentage of the various diseases. As we can see, the chronic otitis media was the most common cause, followed by sensorineural hearing loss. Coming to discussion, 35 children out of 200 have some degree of hearing loss. The proportion of the hearing impaired children in our study was found to be 17.5%, which is very much higher than the national average. Chronic otitis media is the leading cause in 31.4% due to poor hygiene and low socioeconomic status. 6 children with bilateral severe to profound hearing loss with no identifiable wave 5 were promptly advised for hearing aid. Now, for these 6 children who were found to have bilateral severe to profound hearing loss, further evaluation is ongoing to include them in our cochlear implant program, which is soon to start at NRS Medical College under the ADIP scheme. Summary, hearing loss is one of the most common curable disabilities in children if it is identified early and prompt intervention is given. The early treatment of ear infections and suitable hearing prosthesis with speech therapy can ameliorate the burden of hearing loss at a later age. Promoting healthy ear care practices and educating the parents about early signs of hearing loss and common ear infections is required. Conclusion, the study has highlighted the fact that hearing loss is prevalent in our pediatric population. Timely intervention is mandatory. Preparing suitable candidates for cochlear implant is mandatory to bring down the burden of hearing loss. Spreading awareness about the hearing impairment in children and educating the public about the methods for early diagnosis and timely intervention. These are my references. Thank you.
Yes, Dr. Hassan, it was a good topic. You have not mentioned any congenital hearing losses here. Most of them are acquired actually.
So, congenital sensorineural
Can you name some causes of congenital hearing loss? I have 2 questions actually.
Sir, it can be due to influenza, meningitis.
Sorry?
Sir, it can be due to influenza or meningitis during the antenatal period of the mother, or infection.
What are the causes of congenital hearing loss, a baby born with?
Sir, it can be due to the maldevelopment of the cochlea and Mitchell's aplasia, and that is.
Have you heard the name of Torch complex?
Yes, sir.
Torch complex, TRCH.
Yes, sir. Sir, if the antenatal mother suffers from toxoplasmosis, rubella, and cytomegalovirus and herpes infections, it may cause hearing loss in the child.
Of this, which is most common? As because you have uttered the name. It is CMV, okay, cytomegalovirus. And now coming to the cochlear implantation program, in your hospital I think it is going on. Have you seen a cochlear implantation yourself?
No sir, the program is soon to start.
Just going on, oh, you have not seen?
No sir, the program is soon to start in our scheme.
Oh, it started.
We are doing the evaluation for the children.
But theoretically, just asking one thing, only one. Where does the electrode go? In which window? If you know, then just tell. Is it in the round window or in the oval window? Normally.
Okay. What is the earliest time for detection of deafness?
Yes, sir.
Earliest time for detection of deafness.
Sir, ideally all the children after discharge from the hospital, and the OE testing is performed by the pediatricians at the SNCO from where.
The OE actually is being done on the first day of delivery or
Yes.
second day. It is being done by the nursing personnel also. Doctors doesn't require to do it.
Yes.
Okay, it's very simple. Now it has been, I mean, in the program also, first or second day we have to do OE in all the labor rooms, all
Yes,
over
yes.
West Bengal.
Thank you, Nadim. To highlight that we need to do the implant in every medical college and in more regular fashion. So the next speaker will be Dr. Moumita Sen. Her topic is bilateral orbital decompression in a case of Graves' ophthalmopathy.
Good afternoon, respected judges, my seniors and my colleagues. Today I am here to present the bilateral orbital decompression in a case of Graves' ophthalmopathy. Graves' disease, which is also known as thyroid-associated ophthalmopathy, where ophthalmopathy is supposed to be the commonest extrathyroid presentation in 25 to 50% cases. It worsens and turns into an optic neuropathy in 3 to 5% cases, occurs in 4th to 5th decade of life, and females are more prone than males. So the genetic predisposition is mainly HLA-DR, CTLA4, CD25, etc. And they all have a history of either smoking or sudden intake of iodine or having a postpartum period, etc. So it starts with an inflammatory stage. There is a stage of lymphocytic infiltration. There is fibroblastic activation and glycosaminoglycans deposition in the orbital and the periorbital areas. This accumulation of the hyaluronic acid within the muscle and the adipose tissue results in edema and volume expansion. The inflammatory stage also results in the fibrosis of the extraocular muscles and results in fat hypertrophy in the orbit. So a 37-year-old lady, she presented to us with bilateral proptosis since 5 years along with epiphora, and according to the American Thyroid Association, it falls under class 3B. Her complaints were insidious in onset and gradually progressive in nature. She had no pain or blurring of vision or diplopia, and lag of thalamus was present. So before coming to our hospital, she was moving from pillars to poles for a definitive treatment, but she ended up visiting an ENT department in one of the medical colleges, who diagnosed her to be having an uncontrolled hypothyroidism, and she was started with carbimazole 6 months prior to our hospital treatment. Then, due to her uncontrolled hypothyroidism, she was planned for total thyroidectomy 2 months prior from now, and post thyroidectomy she was started on medical treatment. Still no improvement in the proptosis. She was referred to the endocrine department for methylprednisolone infusion. Still no improvement, referred to our hospital for further treatment. So we took the help of the ophthalmological department as well as the endocrine department, and they said that their findings showed that there was lid edema present, there was lower lid edema, there was lid lag present, and on examination she had difficulty in converging. Their assessment said that there was restriction in the extraocular muscle in all cases, exposure keratitis was present, normal disc margin, and VEP said that the visual acuity was normal. This was her preoperative hormone profile. CT, though, is the non-contrast CT, is the preferred imaging, but we did an MRI scan to differentiate whether there is any other pathology present. So here we see that there is bulky extraocular muscle, an axial view. This is the extraocular muscles which are there. There is a edema, soft tissue edema all around the orbit. Again, in the sagittal view, we see that the bulky extraocular muscle and the optic nerve, which was absolutely intact and not compressed. So we planned this patient for a bilateral orbital decompression. We start with a middle meatal antrostomy, an uncinectomy, and we resect the middle turbinate to get ample space for the orbital content to prolapse inside the nasal cavity, and anterior and posterior ethmoidectomy was done along with a frontal recess widening, a wide sphenoid cavity was opened, and we started drilling over the lateral wall of the sphenoid. We, keeping the periorbita intact, we have fractured the lamina pepracia, and this is the inferior wall of the orbit. The periorbita is still intact, we give multiple horizontal incisions from posterior to anterior. Care should be taken that the fat or the extraocular muscles or the nerve should not be injured. We are allowing the fat to prolapse inside the nasal cavity. Similarly, we started the same procedure in the right side also. We started with an uncinectomy, a wide middle meatal antrostomy, a wide frontal recess was open. This is the sphenoid sinus which is open. We fractured the lamina papricia in the medial wall as well as inferiorly also. But we have to take very meticulous measures that the periorbita is not injured. Here we are fracturing the inferior wall. We are taking multiple horizontal incisions from posterior to anterior on the orbital fat to prolapse inside the nasal cavity. A wide MMA should be done so that the sinus should not get stenosed, which will lead. This is the left-sided intraop and this is the right-sided intraop picture. So we had counseled the patient earlier that she may require a lateral approach on a later date as a second look operation if the medial and the inferior wall decompression is not adequate, but we found that we had a happy patient on post-operative day 1 as well as post-operative 1 month. So a coin has two sides. Even this disease, it can be treated both ways. So we started first with conservative treatment, eye care, lubricants, ocular occlusions, started with intravenous medications. A single course of selenium selenate has found that there is a decrease in the thyroid antibodies. Started with glucocorticoids, rituximab, tocilizumab, botulinum toxin in the upper eyelid, and radiotherapy can be given. The surgery, we can do a surgical intervention, medial wall, if it's one wall then medial wall, 2 walls medial and inferior wall, 3 walls medial, inferior and lateral wall, and if 4 wall is planned then medial, inferior, lateral and the superior wall. There are few merits. Why do we want to do an endoscopic orbital decompression? Because it gives an excellent visualization of the vital structures till the orbital apex. A huge amount of decompression can be done because we are making a big cavity. We are getting a big MMA, we are getting a big sinus cavity, sphenoid cavity, a big ethmoid cavity. An excellent exposure of the inferior and the medial wall, and of course no scar. While if we are doing an open approach, there will be periorbital facial swelling, numbness, ecchymosis, these things, and it's obviously more morbid. So I would conclude that orbital decompression is a recognized procedure for the management of Graves' ophthalmopathy, and this endoscopic approach is scoring over external approach because it's safe and well tolerated. Untreated cases of Graves' ophthalmopathy may lead to significant morbidity, and endoscopic 2-wall decompression results in excellent outcome both medically and cosmetically. Thank you.
Thank you, Dr. Momita. It was a good thing. Is there any measurement of proptosis, I mean exophthalmos?
Yes, sir. Sir, we measured the proptosis with the help of the ophthalmology. They have a Hertel ophthalmoscope, exophthalmometer. So with that measures from the lateral orbital rim to the anterior surface of the cornea.
And what is what is the measurement when you take, when we are called for orbital decompression?
Pardon, sir?
What is the actually value? Then you can say that this is having a proptosis or like
yes,
that.
Yes, sir.
There is some measurement.
Yes, sir. Sir, if
and I want to know the normal also.
Yes, sir. So if it's more than 3 mm, from 3 to 5 mm, then it's mild. If 5 mm to 7 mm, then it's moderate proptosis, and 8 or more than 8 mm is severe proptosis.
No, it is 25 to 27 mm, and normally it's 10 to 12. Okay, one thing. And second thing is, why we people, ENT people, are being called for this? Why didn't they call, the orthopedician or neurosurgeon like that? What do we have some advantages over this thing? You have told in your presentation.
Yes, sir.
Every now and then you are telling that thing. Why we are called?
Sir, we are called because if we are going for an open approach, it's more morbid. If we are doing an endoscopic, the main advantage is we have a very good knowledge regarding the anatomy of the nose as well as the orbit. So if we are going via the
sinuses, which is the space where it lies actually.
Yes, sir.
Yeah. And we know more the anatomy of the sinuses.
So-
Yeah.
so if we
you have
are
to
o-
open the maxilla, you have to open the frontal and sphenoid sinuses also, so that it can. And another thing is coming to the, just going another question about the, posterior complication. There
Sorry,
are
sir?
there are a lot of posterior complications here. Post-operative complications, among them is very dead is orbital compartment syndrome. Do you know what is it? Have you heard the name of orbital compartment syndrome?
No.
If not, then go through. Okay, later.
Momita,
Yes, sir.
what is the new or added information in your presentation? Are you passing on any new information or any added information through this paper?
Yes, sir.
What's that?
So, there has been few papers which are suggesting for a balance technique. The balance technique says that we have to do a orbital decompression by medial and lateral approach. Both have to be done. But in our case, we did just the medial and the inferior wall decompression, and that brought marked improvement. We did not go for a lateral approach.
There in literature, this type of surgery? Have you gone through the literature?
Yes, sir.
How many cases
Sir,
are there?
till now 256 cases has been
256
recorded.
cases through the same approach.
Yes, sir.
And you did followed all the medical modalities you showed over here.
Yes, sir.
Rifaxitamab, tocilizumab,
Sir, no, sir. So actually,
selenium.
the
No. Then what medical treatment did you follow in this particular case?
Sir, the medical treatment that was
In your particular case, huh?
So this patient was referred to us from an outside medical institute. So they had already started the patient on levothyroxine, mycophenolate, phenolate, and then she was also given methylprednisolone, 1 gram infusion on 3 consecutive days.
No monoclonal antibody, no selenium.
No, sir.
Okay. Thank you.
Thank you, sir.
Thank you, Momita, to see an excellent presentation, and it's very nice to see how the decompression relieves the disabling exophthalmos of the patient. The next speaker is Dr. Troilokeshwar. His topic is correlation between USG guided FNSC findings and post-operative histopathology in patients undergoing thyroidectomy at a tertiary care hospital, a retrospective study.
A very good afternoon, respected judges, my seniors, teachers and my colleagues. I am Dr. Troilokeshwar Prusti, and I am going to present before you a paper on the correlation between USG-guided FNA findings and post-operative histopathology in patients undergoing thyroidectomy at a tertiary medical college, a retrospective study. I would like to start my paper by introducing before you a case of a 20-year-old Hindu female who presented with insidious onset, gradually progressive, painless midline neck swelling since last 3 years, which is moving up with deglutition and was formed on palpation. So apart from clinical examination, how should we proceed a case of thyroid nodule? According to standard guidelines, we should go for blood TSH parameter and USG of the thyroid gland. According to the USG report, which is based on thyroid scoring, we will plan for FNAC. According to the FNAC report, we will go either for surgical resection or we will do follow-up. The whole motive behind presenting the case was to introduce you to the aims and objectives of my case, which are to determine the demographics of the patients admitted for thyroid surgery, to assess the thyroid score and its association with histopathological report and of the postoperative patients, to assess the Bethesda score and its association with the histopathology findings of the patients. Inclusion criteria includes patients requiring thyroidectomy, patients with thyroid nodule with USG result classified under the thyroid system, and patients with thyroid nodule whose FNAC results are given as per the Bethesda classification. Exclusion criteria includes patients with Graves' disease, raised anti-TPO antibodies, and autoimmune thyroiditis, patients with Bethesda category 1 as per the FNAC reports, and patients with medical illness who weren't fit for general anesthesia. My study is conducted at the Department of Otorhinolaryngology at the Tarsal Medical College from 1st July 2022 to 1st April 2023. It is a hospital-based retrospective, correlational and observational study. Every patient who underwent thyroidectomy during that study period and were part of the inclusion and exclusion criteria were included in the study. My sample size was of 25 patients. Materials included in my study was first ultrasonography of the thyroid nodule and with TIRED scoring. The sonographic characteristics which are associated with higher likelihood of malignancy includes solid component in the nodule, hypoechogenicity, microcalcification, taller than wider in shape, and irregular margins. In this USG, we can see the nodule is taller than wider, and also there is rim of calcification that can be seen in the image. According to various sonographic features, points are assigned and they are accumulated to find out the TIRED scoring. Now, according to the TIRED scoring, we go for further management that we have to do for go for FNAC or not. My second material that was used was fine needle aspiration, which was USG guided and was classified under Bethesda scoring. The Bethesda system is a standardized reporting system for classifying thyroid FNA results into 6 diagnostic categories with the aim of standardizing the FNA results, reporting malignancy rates, and for recommendation of clinical management. According to 6 categories, we can determine the risk of malignancy, and we can plan either surgical resection or we can just follow up. So in my study, data of all the study subjects was collected, the demographic profile was analyzed, the USG-based TIRED score were tabulated, the FNA-based Bethesda score were tabulated, TIREDS and Bethesda results were compared with the final histopathological examination of the patients after surgery, that is, whether it was malignant or non-malignant. Then the data analysis was done and tabulation was done with Microsoft Excel. Now coming to the result and analysis, this table shows the distribution of study subjects according to the age. In my study, most of the patients were in the age group of 35 to 44 years. This table and the pie diagram, it shows the distribution according to the gender. In my study, most of the patients presenting with thyroid nodule were female. But the thing is, the incidence of malignancy were more among male, that is 66.6% compared to 52.6% in case of females. In this table, I have shown the distribution of patients according to the TIRED scoring of USG. Most of my study patients were in TIREDS 4. Now, in this table, I have calculated the risk ratio of the patient with suspected histopathological finding. In this study, in this table, I can see that patients with TIREDS 4, TIREDS greater or equal to 4, were having 5.53 higher chances of being suspected with malignancy in histopathological finding compared to those patients with TIREDS score less than 4. Now, incidence of malignancy, that was Bethesda scoring, was compared with post-operative histopathological finding, and the percentage of malignancy were calculated. This table is not correlating with major studies that were done in the past and seen in major literature because of the small sample size. Now, coming to the discussion, thyroid nodules are a very common disease with only 4.5 to 6.5% being malignant. A steady increase in the incidence rate of thyroid cancer, especially papillary CA, has been noted in recent decade all over the world. This increase is not due to real increase in frequency, but due to increase in detection rates. USG is an accurate method of detection, that is detection rate of 16 to 67% compared to 3 to 7% via palpation. However, it has a low accuracy in differentiating between benign and malignant nodules. Therefore, USG-based TIRED has been introduced with the aim of establishing a standard method of nodule description, defining the suspicious characteristics, putting the nodule into a risk category, identifying those nodules in which FNA is needed. FNA has proven to be highly sensitive in establishing a diagnosis, differentiating benign from malignant, and thus avoiding unnecessary surgeries. From our study, we have found that incidence of thyroid nodule, as discussed earlier, is greater in age group of 35 to 44 years with female preponderance, but the probability of nodule being malignant is greater in case of males, which was in concordance with the study carried out by Joanna Grace et al. where they observed that the majority of the patients were in their 30s, 40s, and 50s, and majority of them were females. From the study, it is concluded that the USG and FNAC are sensitive methods and reduce the risk of unnecessary surgeries. Although USG is a non-invasive, harmless method, but its use as a single tool is not advocated, and results should be correlated with FNAC findings before going for surgery. There are some shortcomings in my studies. As mentioned earlier, the study was carried out with a small sample size. USG and cytology reporting were done by different operators, causing inter-observer variations. These are my references. Thank you.
Thank you, Dr. Pusti. Very good topic you have just told us. Nothing much to ask you, just only asking one thing. Can you name some, thyroid disorders, disease where FNA and HPE differ mostly? 2 or 3 thyroid, tumors.
Sir, I won't get the question. HP
And FNA findings mostly differ.
Yes, sir, in my study there were...
We are misguided actually. Mike.
So,
there is some HPE differs actually.
yes, sir.
In some thyroid disorders, disease.
Sir, there were few cases with Bethesda 3 which were benign, as well as one case of Bethesda 4 which is benign on histopathological examination. So I cannot completely tell that it will be malignant by FNAC. I have to use USG as well. But it is seen that results USG as well as FNAC finding will not always correlate with the histopathological finding. But greater probability of being malignant in histopathological examination, on the basis of that we are doing the surgeries. We cannot completely tell for sure.
Do you have any frozen section, facility in your operating room? Frozen section? Frozen section?
Projects?
Frozen section ache ekhane?
In our department there is no frozen.
You don't have?
No, sir.
Okay.
Dr. Pusti, what was the actually topic of your presentation?
So in this paper, I was comparing the USG
between USG guided FNAC and histopathology.
With histopathological and FNAC based.
Nothing to say about USG reports. And your presentation comprising of more than 50% of that non-essential part. Am I clear? Huh?
No, sir.
Thyroids should not come in your presentation. Am I clear? Your presentation is purely between the Bethesda system of scoring and histopathology.
No, sir. No, sir.
What then? Why this? Go to your headline topic.
So actually,
no. You are simply deviating from your topic. It is not acceptable in a presentation.
So when you are doing USG,
just go to your topic and yes, go to your presentation. Then, where it is? Thyroids is where in these headings?
So first we are doing USG, after that we are doing FNAC. USG reporting is there, FNAC reporting is also there.
You are not comparing according to your heading. You are not comparing USG findings with histopathology. You are comparing only FNABC reports with histopathology.
So in my aims and objectives I have written that. I am comparing thyroids with it.
So then why you have omitted Bethesda type 1?
So Bethesda type 1, they are non-diagnostic. Repeat FNAC has to be done.
Then what is the importance of Bethesda type 1? Do you know that?
We have to
if your institutes produce a significant amount of Bethesda type 1, that means your system of sampling should be corrected actually.
Yes,
so it should be included in your study. So it should be included in your study.
Non-diagnostic, therefore repeat FNAC has to be done. After that, if this conclusive result is there, we'll include.
Thank you, Trailokeshwar. The next topic is a challenging case of laryngeal hemangioma, and the presenter is Dr. Bishwajit Saha.
Good afternoon, respected judges, seniors and my fellow colleagues. Today I am going to present some challenging cases of laryngeal hemangioma. So laryngeal hemangiomas can be classified into adult and infantile variant. Incidence of infantile variant 4 to 5%, However, incidence of adult variant can be documented in any literature due to scarcity of case reporting. Males are more prone to develop adult hemangioma and usually present with dysphagia, hoarseness, breathing difficulties and recurrent bleeding in the form of hemoptysis. So, I gonna present two cases. So, I gonna present two cases of laryngeal hemangioma, both in adult male, both treated surgically with coablator assistance. So, moving on to case 1. A 30-year gentleman visited with complaints of breathing difficulty while working in bend down position for last 10 years and noisy breathing during sleep for last 10 years. He visited a hospital with video laryngoscopy report which shows hemangiomatous mass completely obscuring the laryngeal inlet. After that, he underwent intralesional sclerosing agent injection 7 times, but the lesion does not subsided. For that, he planned for debulking of this lesion. Before going for surgery, he underwent right external carotid artery branch embolization based on CT angio report for better control of bleeding during surgery. He underwent coablator assisted complete excision, but 8 months after the surgery on fiber optic laryngoscopy, the disease recurrence noted. After that, he was referred to our hospital for further management. On examination, there was tracheostomy tube in situ. On palpation, there was no external swelling. Laryngeal crepitus was present. On auscultation, there was fine bruit. We did fiber optic laryngoscopy for this patient, and we can appreciate from this that there was hemangiomatous mass involving the supraglottis, glottis, right area epiglottic fold with limited movement of the right hemilarynx and good closure of vocal cords on adduction. We did MRI for this patient, and which gave us idea about the extent of the disease up to the right piriform sinus area and epiglottic area. We did CT scan, CT angio for this patient, which gave us idea about the feeding vessel, which was nothing but superior laryngeal branch of right superior thyroid artery. So we planned for coablator assisted excision of laryngeal hemangioma external approach, in which we monitored the lesion endoscopically and did the main surgery externally. After exploration of neck, we ligated the right superior laryngeal right superior thyroid artery for better control of bleeding during surgery. After that, our main target was to locate and identify the feeding vessel. We can appreciate that this is the main mass and this is the feeding vessel. So we ligated the feeding vessel, and we can appreciate that we have ligated the feeding vessel and cut the vessel. Then the mass was extended up to the right piriform sinus area. We dissected the mass from that area, and during surgery there was a mucosal breach which repaired carefully. After removing the mass, we sent for HP, which came out to be cavernous hemangioma. Due to mucosal injury, we suspected a breach, salivary fistula. So we kept the patient, we inserted Ryle's tube and kept the patient in nothing per mouth. Patient was kept sedated and shifted to ICU with mechanical ventilation, which gradually weaned off, and the patient shifted to general ward on postoperative day 5. We wanted to wean off this patient from Ryle's tube feeding, so and start oral feed. For that we did gastrographin study. We can appreciate that there is a spillage in the right piriform sinus area. So we discharged this patient with Ryle's tube feeding and uncupped double lumen tracheostomy tube and started propranolol 10 mg once daily dose, and gradually increased to 20 mg twice daily in conjunction with medicine department. So we did fiber optic laryngoscopy 2 months after the surgery. There was healthy granulation tissue in the lateral wall of pyriform sinus, which suggested mucosa has healed. So we started oral purine diet, and after 1 week of oral diet tolerance, we removed the Ryle's tube. This is the flexible endoscopy. This is the flexible endoscopy done 3 months after the surgery. We can appreciate that the concerned area there is healthy granulation tissue and no sign of recurrence. Moving on to case 2, a 64-year gentleman referred to us with recurrence of recurrent hemoptysis, change of voice for last 6 months and progressive respiratory distress for 3 months. Fiber optic laryngoscopy showed mass arising from the left aryepiglottic fold obscuring the laryngeal inlet. He was underwent tracheostomy and DL biopsy earlier, which came out to be lobular capillary hemangioma. We did MRI for this patient, which came out to be a well-defined broad-based enhancing space occupied lesion arising from the left aryepiglottic fold. Before going to surgical intervention, we did selective embolization done via transfemoral route under local anesthesia. The embolization done with polyvinyl alcohol particles. The main feeder vessel for this case was ascending pharyngeal artery. So we can appreciate from this video that the mass has been dissected from the aryepiglottic fold, and we can appreciate the whole tumor is excised with minimal bleeding and without injuring the interarytenoid region. We did fiber optic laryngoscopy 2 days after the surgery, and we can appreciate from this video that there is normal laryngeal function in terms of airway, and voice and swallowing function of this patient was absolutely normal. So we removed the tracheostomy tube 3 days after the surgery, and though no recurrences documented 3 years after the surgery. So coming to the discussion, adult hemangiomas are slowly progressing benign vascular tumor of endothelial origin. No causative and predisposing factors have been identified till date, and laryngeal hemangiomas in adult are very uncommon, and they occur at any age, and adult commonly involve the supraglottis. So there is no consensus regarding the treatment option of the hemangiomas due to their rarity. Options like ovulation assisted excision, microlaryngoscopy, laser excision with CO2 laser, argon plasma coagulation is the treatment option for with minimal bleeding. So I conclude laryngeal hemangiomas are very rare. Perioperative and embolization and coabulator assisted excision ensure minimal blood loss, and near complete excision is required for prevention of recurrence of disease. These are my references. Thank you.
Thank you, Dr. Shah. Do you have laser in your institution?
Huh?
Laser? Do you have laser?
No, sir.
You don't have laser. Okay. Have you heard the name of ultrasonic scalpel?
Yes, sir.
What is the advantage of using that thing against coabulator?
Bleeding is less.
Bleeding is less.
And
in which coabulator?
Injury to surrounding structure is less.
Compare just between two. Just 1 or 2 points. It is also called as harmonic scalpel.
Yes, sir.
It works only with vibration. Huh? It coagulates the protein, which just transfer into coagulum, which seals the bleeding actually. Recurrence is very rare. Okay?
Yes, sir.
Thank you.
Dr. Shah, what is the take-home message from your presentation? What is the take-home message from your presentation you want to pass to the audience?
So, recurrence is very common for this lesion. So, meticulous planning and teamwork and assessment is very important for treating laryngeal hemangioma.
Thank you, Vishwajit, for presenting a challenging case, a series of challenging cases. Then the final presenter of today is Dr. Sheikh Jishanul Haq. His topic of presentation is posterior triangle of the neck and uncharted territory. Over to you.
Good afternoon, my respected teachers, seniors and colleagues. Today my topic of presentation is posterior triangle of neck and uncharted territory. This is one of the most anatomically and surgically significant area of the neck is posterior triangle. It is one of the most complicated surgical field of our body due to presence of several neural structure and vessels. Then what are the aims and objectives? The aims and objectives are to study the anatomy of the posterior triangle and the clinical radiological assessment of the posterior triangle lesions, intraoperative finding during surgery, and to study the postoperative complications. Anatomy. This area is bounded by anteriorly by posterior border of sternocleidomastoid, posteriorly by anterior border of trapezius. Base is formed by clavicle and the apex is formed by the junction point of the two muscles. Roof is formed by investing layer of the deep cervical fossa. Floor has three muscles: splenius capitis, levator scapulae, and splenius medius. And the omohyoid muscle further divides this triangle into two more triangles, that is occipital triangle and subclavian triangle. Now the important nerves and vessels of this area are spinal accessory nerve, Erb's point, and the branches of brachial plexus, that is dorsal scapular, long thoracic, nerve to subclavius, and suprascapular nerve. There are also four cutaneous branches. These are occipital, great auricular, transverse cervical, suprascapular, and the suprascapular nerve. And the important vessels, these are external jugular vein and the third part of the subclavian artery. Now there are three cases that I have chosen for my presentation. Case number 1, a 23-year-old female presented with swelling on the left side of the neck since last 3 years. On examination, it was 2 by 3.5 centimeter mobile, cystic, palpable, non-tender, well marginated, and non-illuminating swelling over the posterior triangle of neck. The clinical radiological assessment. USG, MRI, and FNAC were done. USG finding was with spongiform heterogeneous ecotexture. MRI finding shows hyperintense lobulated lesion in T1 weight image, and the FNAC report come as the phenollymphatic malformation. Intraoperative finding during surgery. Now we can see that this surgery was done by transcervical approach under general anesthesia after proper ASS and SD. Horizontal incision were made. Horizontal incision was made above the most prominent area of the swelling, and flaps were raised. Now we can see that the spinal accessory nerve it got injured by the traction. This mass was excised. The mass was removed from this area, and the sample was sent for HP. It came out as phenollymphatic malformation. The case number 2, a 16-year-old male presented with swelling over the neck for last 3 years. On examination, 4 by 3 centimeter, soft, palpable, non-tender, well marginated, non-transhuman, not fixed to underlying structure or skin. Clinical radiological assessment. USG, MRI, and FNAC were done. The findings were same. USG feature was well marginated masses with spongiform heterogeneous ecotexture. MRI shows hyperintense lobulated lesion in T1 weight image, and the FNAC was came out as phenollymphatic malformation. Now during the surgery was done by transcervical approach, the same as the last case, but in case here, during the raising of the flap, the great auricular nerve was damaged by the monopolar cautery, and after this the mass was excised from the structure, and the sample was sent for SP and came out to be phenollymphatic malformation. Now the third case, a 50-year-old male presented with progressive swelling in the left side of neck since last 7 years. On examination, it was soft, palpable, non-illuminating, non-tender, and mobile, and not fixed to and skin or underlying structure. This clinical radiological assessment, USG, it shows well circumcised ovoid masses with homogeneous imaging characteristics of fat. MRI shows hyperintense lobulated lesion in T1 weight image, and FNAC came out as the lipoma. In this case, transcervical approach was done, and under GA after proper SS and SD, flaps were raised, and all the structures that were preserved during this OT. we can see that the spinal accessory nerve, it has been separated from the operation field by a nasogastric tube. Sample was sent for HP and came out as lipoma. Now, complication of the OT. As this area is rich of nerves and vessels, one should keep in mind a fine anatomical knowledge about this area, or otherwise it can hamper the quality of life of the patient. In case 1, traction injury to spinal accessory nerve took place intraoperatively and patient complained of unable to comb her hair, that is difficulty in overhead abduction. In case 2, a great auricular nerve was sacrificed in this case while elevation of the flap by monopolar cautery. Patient complained of loss of sensation in the left parotid area, post-auricular and external ear. In case 3, all important structures were preserved in this case, but post-operative seroma was developed. On repeated aspiration and compression bandage, it was resolved. Now, what are the take-home points? The take-home points are: the anatomical knowledge is a key to operate the posterior triangle lesions. One should keep the differential diagnosis in mind for posterior triangle lesions, and post-operative follow-up for complication and rehabilitation to be done meticulously. Thank you.
Thank you, Dr. Hawk. Just some anatomy. What group of lymph nodes are found in posterior triangle?
Sir.
Level
5 lymph nodes, sir.
5?
Yes, sir.
What are those 5? Just you have to name the lymph nodes.
Sir, the lymph nodes are present over the posterior border of the sternocleidomastoid muscle.
No, I'm just asking the name of the lymph nodes. Okay. It is being subdivided by 2 triangles actually, this posterior triangle. What is that muscle called?
Sir, the omohyoid muscle actually divides.
Which belly?
It's the inferior
belly.
Of the
And just small anatomy. What is the original insertion of sternomastoid?
So, sternocleidomastoid muscle. So the origin is.
It is not today is only sternomastoid, not clido. Probably.
Sternocleidomastoid.
Okay, anyway. Okay. Sternomastoid.
Sir, origin is mastoid area.
Mastoid area?
Mastoid tip of mastoid. Sorry, sir. Origin is from the clavicle, and it inserts in the mastoid area.
Then why it is called sterno? It definitely has some relation with
this
sternum.
Sternum, clavicle, and mastoid. 3 muscles.
You have to know the anatomy, huh? Okay.
Now all the topics now been open for discussion to the forum. The participants are requested to please come on the dais. All the participants. Now anybody can ask any questions to the participant if they are interested too.
No, not only questions. We need suggestions and discussion from the floor. So all participants, you have done very well job. You have prepared well. This is a platform for you to present yourself. So please, all the participants come on the dais, get your certificates. I request Dr. B.K. Roychaudhary sir, please come on the dais. Dr. J.N. Guttu sir, please come on the dais. And Professor Sumanto Datta sir.
Now I would sir দুই এক কথা বলুক স্যার at the age of 88 স্যার এখনো স্টিল প্রত্যেকটা ক্লিনিক্যাল মিটিংয়ে মেটিকুলাসলি আসেন এবং জুনিয়রদের এনকারেজ করেন, মানে দিস ইজ সামথিং হুইচ ইজ কমেন্ডেবল। স্যার একটু জুনিয়রদের উৎসাহ দেওয়ার জন্য দুই এক কথা।
এক নম্বর হচ্ছে এই হলটা, এই হলটাতে কতবার যে আমি এসছি তার কোনো ঠিক নেই ইন মাই ক্যারিয়ার, কিন্তু এত খারাপ ছিল না, এত খারাপ ইন দ্য সেন্স যারা নীলরতনে কাজ করেছে এত ইকোয়িং, এটাকে অনেক সাজিয়েছে, নাম পাল্টেছে, আগে স্মল লেকচার থিয়েটার ছিল, এখন নিবেদিতা হয়েছে, কিন্তু এত ইকোয়িংয়ের জন্য কিছু বোঝা যায় না। এটা হচ্ছে আমার ফার্স্ট ইমপ্রেশন এই হলটা। সেকেন্ডলি, আমি সবগুলো শুনতে পাইনি, যে কটা দেখেছি, আই ফার্স্ট কংগ্রেচুলেট অল অফ ইউ। তোমাদেরটা শুনতে পাইনি, লাস্টে দুটো তিনটে যেগুলো দেখেছি তার মধ্যে কয়েকটা পয়েন্ট আমি একটু হাইলাইট করতে চাই। সেটা হচ্ছে স্পেসিমেনের মার্কিং। আমি বলছিলাম অমিতাভকে, দেবঙ্করকে, যে সিরিজ লাগিয়ে স্পেসিমেন মার্কিং, ক্যান ইউ টেল মি এ 10cc সিরিজ, হোয়াট ইজ দ্য লেংথ অফ দ্যাট? পারবে কেউ? এখন কেউ বলার আছে লেংথ অফ 10cc সিরিজ? কেউ বলতে পারবে না, বিকজ দ্যাট ইজ নট দ্য স্ট্যান্ডার্ড অফ মেজারিং স্পেসিমেন। তোমাকে স্কেল দিতে হবে। কাজেই আই রিকোয়েস্ট অল দ্য সিনিয়র্স যারা এটা করছেন, এখানে দেখানো হয়েছে আজকে, এরকম করবেন না, কারণ আপনাদের কাছ থেকে বাচ্চারা শিখবে। ইট ইজ এ রং ওয়ে অফ মেজারিং এন স্পেসিমেন। একটা সিরিজ লাগিয়ে দিলাম, সেটা কত লেংথ আমরা কেউ জানি না, এটা একটা মনে হয়েছে। 2 নম্বর হচ্ছে যেটা হেমাঞ্জিওমা। হেমাঞ্জিওমা আমরা অনেক করেছি। মাই প্রেফারেন্স হচ্ছে coagulation diathermy of the cavernous hemangioma. Coagulation diathermy করে তাতে না হলে পরে দেন ইউ গো ফর এক্সিশন। করার পরে এটা কোগুলেশন হয়ে শক্ত হয়ে যায়। আই ডোন্ট নো, দিস পেশেন্ট actually operated 6 times, na? 6 times in 6 institutions. Very good to see such type of cases. এবং পরে কবলেশন লেগেছে, কবলেশনটা লেগেছে তার মানে শক্ত হয়ে গেছে বলে তারপরে। সো ভেরি নাইস। আর লাস্ট কেসটা কি দেখলাম জানো? Posterior triangle. I see many cases of tuberculous lymph nodes, and mostly commonly see in posterior triangle. Have you seen any কে করেছেন ওটা আপনারা? কোনো টিউবারকুলাস লিম্ফ নোড পেয়েছেন বা অপারেশন করেছেন? So that is my experience. So I thank you so much. I am so happy to come over here, and একটু দেরিতে আসলেও আসতে পেরেছি, আপনারা কিছু মনে করবেন না দেরিতে এসেছি বলে। থ্যাংক ইউ সো মাচ।
গুড্ডু স্যার দু একটা কথা বলুন। গুড্ডু স্যার say few words, sir.
Good afternoon, everybody. I am very happy to be invited by the President and Secretary of AOI West Bengal branch, and I am very happy to see, since I came from 1978 to Calcutta, the standard has gone to national level, and I hope it will go still further. The bar has been raised every year, so I am very happy to see the AOI West Bengal branch going very high and high, and they are becoming exemplary in the country.
I would now request Professor Dr. Shumanto Datta sir to hand over the certificates to the participants. I will call one by one. Please come in front and take your certificates. Prior concluding, any suggestion from the floor, from the senior members?
So just to encourage, not to just to encourage you, but tell you the fact that all the papers were very nice and we very much enjoyed. And to that lady, the first who presented, just for you one note, that don't make your slides so crowdy, because that we actually lost our interest in going through it. And secondly, you always consider that the hall may not be dark. So always go for black and white, on black on white background. So put less information in the slide and make it very readable. that is absolutely very important. And really, it was all very nice, and we are very happy.
Same thing, I think. I think I will add to what Dr. Gurtu said, that the standard of our West Bengal presentation has been raised to national level, you said. I would say West Bengal presentations are the national benchmark at the moment. So other states can compete with us. That's the greatness of all these youngsters who are raising the bar every day, and we hope we will definitely continue to do so. Thank you.
Now it's the time for handing over the certificates. First, Dr. Ayesha Shirin, come in front, sir. Dr. Shouvik Mondol, Dr. Mohammad Nadim Hassan, Dr. Rupsha Shaha, Dr. Troilokeshwar Prusti, Dr. Bishwajit Shaha, Dr. Vyush Nag Mukherjee, Dr. Sheikh Jishanul Haq, Dr. Momita Sen. So finally, it's the time for our honorary secretary to come on the dais and give the vote of thanks.
Thank you all the participants, you did a wonderful job. The winner and first runner up of all the participants in all our monthly clinical meeting throughout the year will get certificate and gold medal during our 51st annual conference. Okay, so congratulations to you and best wishes for your upcoming days. And I thank all our members for being here and encouraging all the participants. And I thank NRS Medical College, ENT department, and our to organize this clinical meeting in association with AY West Bengal. And I also thank CIPLA Cresta division for sponsoring today's program. And is there anyone from CIPLA Cresta? And I thank also our audiovisual partner for recording this program, and it will be uploaded in our YouTube channel. So those who have missed, you can see it in our YouTube channels. And follow our YouTube channel. All the events are uploaded there. You can see them there. And I also request Dr. Bidhan Rai to come on the dais, because our next big event will be a 2-day surgical workshop in Holdia. There is a little confusion regarding the dates. It was initially posted on 8th and 9th July, but as the Panchayat election is posted on 8th July, so we are thinking about changing the dates. But it will be announced soon. Before that, I want request Dr. Bidhan Rai to invite you all.
Okay, actually what we did decided in our previous days that association activity should shift from Kolkata to periphery a little bit to promote the district doctors and surgeons. As a part of that, to start with, we have decided to set on 2 days live surgical workshop at Holdia, that is on Saturday afternoon and Monday morning. The particular date was decided on 8th and 9th July, but because of the upcoming Panchayat election, we are bound to shift it probably on 15th and 16th July. I will try my level best to make the program a successful one. I invite all of you to come over there and participate in the event. Thank you very much.
সবাইকে একটু রিকোয়েস্ট করব ফুড প্যাকেটসগুলো একটু নামিয়ে রাখবেন, একটু একটা ফটো তোলা হবে। আর সিপ্লার থেকে ক্রেস্টা ডিভিশনে সৌভিক উইল সে ফিউ ওয়ার্ডস। মানে আওয়ার পার্মানেন্ট জাজেস, পার্মানেন্ট পোস্ট, কিন্তু এটা মানে জিবিতে পাস করাতে হবে।
Very good evening, respected doctors, and thank you very much first of all to let us participate with you all in this beautiful event. And on behalf of Cipla Cresta, I Shovik, thank you all for coming here, and I hope our association with AOI will continue for entire year and upcoming years also. And on behalf of Cipla Cresta, I would like to request to also help support us as the way you have supported us before. Though we are quite new in the particular segment and our footprints are also small, but still I would like to request to support us as you have supported our respiratory wing before, so that we can also in a better way participate and follow our motto of Cipla, caring for life. So for a few brands we would like to request, and that is our Duonez and Bilafab-M tablet. So, and Bilafab-M ODT, which is recently launched. So overall, these two brands we would like to request your support extended to us. And that's it. Thank you very much all the doctors for coming here. Have a good evening and good weekend. Thank you, sir and madams.